I'm a general pediatrician working in the United States. I'm Diplomat American Board of Pediatrics. Today I'm going to talk to you about cystic fibrosis. It is something which is very hard for you to understand because it is a disease which is very common in West, but in Pakistan, you're not going to see it frequently. It's very uncommon. So when you don't see patients with a disease, it's hard to understand that disease. So I will try to explain it to you in a way that it helps to clear your concept, because you need to know this disease, and it confuses you a lot. So let's get started, and let's see if I can help you clarify some of your concepts. So on the basis of 2012 statistics, there are about 30,000 people in North America who have cystic fibrosis. It's a lot of them. And their life expectancy is around 40 years. Actually, about more than 20 years ago when I started working here, the life expectancy was much lower versus improving with newer therapies. And a lot of cases are diagnosed, and most of the children are diagnosed at birth by a program which is called as a newborn screening program. It is very different incidence based on the race. So it's almost 1 in 3,000 in whites or Caucasians. Is much less in other ethnicities. But as we are more aware of the disease, the cases are being diagnosed in Asia and Africa as well. So starting with a patient is usually a good idea to try to understand the disease, because whatever we are studying in books, we have to apply it on a real patient to treat them and to keep them healthy. So let's start with a 15-month-old who presents to peers with history of recurrent pneumonia, failure to thrive, and chronic diarrhea. He was also recently hospitalized with dehydration. The most important features of this disease are respiratory and GI. Children, because if they are not going to get enough nutrition, they are not going to grow. So they don't gain weight, and then they don't get taller either. So they present with failure to thrive, which means that this child, if you are going to plot this child's weight on the growth chart, the weight is probably going to be around 5th percentile and height is going to be around 25th percentile. So there's going to be a discrepancy. These children cough a lot. They just keep coughing all the time, and they constantly get sick. Sometimes they get diagnosed with bronchitis, sometimes they get diagnosed with pneumonia. And their parents usually, they can actually recall that when baby was born, everyone was worried because this baby didn't pass stool for a few days. Like when we will go ahead and ask mom of this 15-month-old, she may tell us that, oh, baby had a bowel movement after 3 days, and we are really getting worried about it. So babies will have this kind of history. And these children will get dehydrated very quickly, as we are going to talk more about it. This disease has a lot to do with salt depletion. So in summer months, these kids can get dehydrated quickly. So when you will examine this child, you will see a lot of things on this baby. You might see a lot of runny nose with a lot of yellow-green discharge. You will listen to lungs and you will hear a lot of wheezing and crackles. And the kid is going to look very thin and very low weight. You might notice some polyps in the nose. You might notice rectal prolapse, which happens due to diarrhea. So most children in United States are diagnosed now based on newborn screening. So they are actually tested for cystic fibrosis at birth, because this is one of those diseases where first 2 weeks of life or first month of the life makes a huge difference in your quality of life. And there are also some diseases which are screened, which are, if they're not picked up, the baby is going to die. So the newborn screening test, which you can also do later on too, on this baby, which we are talking about, our 15-month-old, is called as immunoreactive trypsinogen. So you can test for it and it's going to be elevated. And if this test is elevated, they actually do a DNA testing or a genetic testing, which is called as CFTR. We are going to talk about this mutation in a minute. For our 15-month-old baby, if you try to think which test you are going to do in this scenario, a sweat chloride test can be done because our baby is older. So the current recommendations is to confirmation of the newborn screen test with a sweat test. So there are multiple mutations of CFTR gene, and one of it, which is very common, is called as F508. They're all genetics testing, which I'm not sure how much of it is available in Pakistan, but these are usually done to make the diagnosis. Sweat chloride test is something which you need to know is important for you. So they get some sweat from baby, and then they are going to go ahead and test it. So it is elevated, typically more than 60 milliequivalent per liter. And the numbers are a little bit different based on how early you are going to do the sweat chloride. So as you can see with this table, that is less for infants and is older for children. So as I said, we are going to talk a lot more about CFTR. The actual name of CFTR gene, which I will say this word again and again, is cystic fibrosis transmembrane conductance regulator gene. And the disease which you get due to this problem is a multi-system disease. It affects a lot of systems, like it definitely affects, as we talked about, lungs and GI, but it's also going to affect the sinuses, is going to affect fertility, is going to affect muscles and skin, and can cause clubbing as well. So it's like a multi-system disease. It is inherited in an autosomal recessive pattern, and as you can see, there are six class of mutations. Okay, so there are different type of impairment. I'm going to show you the next slide because it's easy to understand this table with a picture. So first note that CFTR, how it works. Okay, it's important for you to understand what it does. So it's basically a CAMP activated chloride channel regulator, which is located on the surface of the epithelial cells, and it's on the top of the epithelial cells of the respiratory tract, pancreas, sweat glands, salivary glands, intestines, and reproductive system. And what it does is that it decreases the function of a chloride channel, which is in these epithelial cells. So this picture explains this much better. So as you can look at this slide, that with this normal channel, the chloride ions are able to go outside. These little blue bubbles, they are able to go out from the cell outside. Well, the one which is on the other side, which is the defective one, is not doing it. So what happens is that due to this, the secretions on the top of the epithelial surface get very thick and dry. And all problems which you see with cystic fibrosis has to do with this. So patients with cystic fibrosis, they can have a non-functional channel, or they can have a channel which works partly, and due to which the sodium and water are drawn into the cell. And as I said, that the top of the epithelial surface gets dry as these cells suck all the secretions. So in order to get this concept clear, think about your mouth. If you have less saliva, the secretions will get, I'm sorry, your mouth is going to have less secretions, and your mouth will feel dry. So the same way, all the surfaces get drier and drier, and it causes organ dysfunction. So this is like a diagram, and this is something which explains that there are so many different mutations that not all patients with cystic fibrosis are same. Some of them have very severe disease, and some of them will have very mild disease. For some, one organ system will be involved, and for some other will be involved. So there's a huge variety in, as we call, phenotype based on genotype. So this picture kind of explains all the important components of cystic fibrosis disease. It's a very important picture. So starting from top to bottom, as I would like to explain, and before I go to different systems, I want you to look at the B and C part of the diagram, and it shows you the normal airway. It's inside your lungs as a part of a bronchiole or a bronchus. So you can see that the airway is constantly lined with a thin layer of mucus. And when it does not happen that way, the mucus becomes very thick and sticky. Okay, all of you had cold, so remember when you take these cold and cough syrups, and your sputum gets very, very dry, or your nasal secretions get too dry, they get so sticky. The same thing happens inside your lungs. So these secretions get very, very thick, and due to which they irritate the lining of the airways, due to which they get damaged. Due to this, they can get bacterial infection, because all this mucus which flows, it actually washes your airways, and it does not let bacteria cause infections. These are our body's natural defenses. And due to a lot of irritations and infection, you can even have blood in the airway. So back to the A part of this diagram, the sinuses, the patient will have recurrent sinusitis. In lungs, all that thick, sticky mucus will build up, and they will get recurrent bacterial infection, which means bronchitis and pneumonia. In the skin, the sweat glands produce a sweat which is very salty. Actually, on the skin is a little bit different. The salt actually comes out. So it's a little bit reversed. A lot of people get confused with it because it's actually coming from the salivary glands. So but the sweat becomes very salty. So if it is like hot, and child is sick and is getting dehydrated, the child will have a very bad form of salt depletion. In liver, as you move down, the bile becomes extremely thick, and it blocks the bile ducts, which starts causing damage to liver. In pancreas, it does the same thing. The secretions are very thick, so they start blocking the pancreatic ducts, and it damages pancreas, and it affects both exocrine and endocrine function of pancreas, which means that pancreatic enzymes, which are supposed to digest all of our nutrients, are not going to work. And then when you get damage in pancreas, you will develop diabetes. Now, intestines, due to this, cannot absorb nutrients completely. And in reproductive organs, these thick secretions cause infertility. So moving on, as I explained it to you, so now everything which I'm going to tell you about the clinical presentation in lungs will make sense. So your mucus plugging of airways causes to chronic progressive obstructive pulmonary disease marked by chronic inflammation and infection, and progressive small airway obstruction and bronchiectasis. So this chronic sinopulmonary disease is manifested by persistent colonization by multiple pathogens. So these children and teenagers have a very miserable life. They keep getting admitted to the hospital again and again. They cannot do what other kids do, run, play, and they miss a lot of school because they keep getting sick. And they have this chronic cough and sputum production. And the chest X-rays will show a lot of abnormalities on it. The airway obstruction will be manifested by wheezing and air trapping. The children usually do not develop nasal polyps. If you see nasal polyp in a child, the diagnosis of cystic fibrosis is very likely. And then if you do the CT or X-rays of sinuses in these children or teenagers, you will see extensive sinus disease. Pulmonary disease is the major cause of morbidity and mortality. Children die due to lung disease. Their lungs get so much damage, they start having hemoptysis, and they are on the transplant list many times. But most of the time, it's their damaged lungs which kills them. So this is kind of a series of X-rays which show how this disease gradually damages the lungs. So the first one, the disease is milder. As it gets severe, you can see that you can see all the inflammation in the bronchioles, and you can see that lung parenchyma is now affected and getting damaged. This is a CT scan which actually shows you swelling of the bronchial tree, and this kind of the disease actually drives the name cystic fibrosis from the lungs. And this name, which I usually tell students as they try to think where did the name come from. So it came like a long time ago when all diseases got their names from autopsy findings. So when they looked at the lungs, they were fibrous and they were cystic. This is a picture of nasal polyps in a child, which will give you diagnosis of cystic fibrosis. Moving on, GI symptoms, as I explained to you in that picture, how it causes the damage. So now you can see how all those things are doing. So when you have exocrine insufficiency, it causes malabsorption of fat, protein. So that's why you have those large bulky stools. And it can also cause intestinal obstruction. The newborn can have meconium illness, like meconium is so thick that they get intestinal obstruction from it. They can have perforation. They can have meconium peritonitis. And as they get older, they can again get bowel obstruction due to their constant dry stool or bulky stool, and that keeps happening again and again. They don't grow well. They are very thin, and then they are trying to strain hard to pass these large bulky stools, so it can cause rectal prolapse. And when the pancreas gets damaged due to dry secretions, it causes acute pancreatitis, it will cause chronic pancreatitis, and you will see all those abnormalities on imaging. In liver, you will see prolonged neonatal jaundice. Actually, cystic fibrosis is a big differential diagnosis for prolonged neonatal jaundice. Then as his liver starts getting damaged, they can develop biliary cirrhosis. Nutrition, I already talked about it. You will see failure to thrive. They can also have hypoproteinemia and edema, and a lot of complications due to fat-soluble vitamin deficiencies. Hemorrhagic disease of newborn can happen, which kids, babies start bleeding from all orifices, nose and gum bleeds, and they die with it. Here, vitamin K is actually given to all newborns at birth to prevent hemorrhagic disease of newborn. So this is a picture of meconium ileus, with which lot of babies present and get diagnosed. So other clinical presentation, as I already told you, is acute salt depletion. So these salt loss syndromes with an abnormally high sweat electrolytes. Male infertility and decreased female fertility is again due to thick cervical mucus in female, and in male they can have obstructive aspermia. So in 2008, Cystic Fibrosis Foundation actually tried to come up with like a combination of features which you can see, or phenotypic features like lung damage, GI symptoms, male urogenital abnormalities and salt depletion syndrome, nutrition failure to thrive, and match it with the genotypic test, okay? Because everyone was so different, so the whole concept of diagnosis of cystic fibrosis got changed. So now it's based on the presence of some phenotypic features, family history of cystic fibrosis, and a positive newborn screen, or if you are going to look at the test in Pakistan, it's going to be an elevated IRT, as well as sweat chloride concentration. Moving on to therapies, there is no definite treatment yet, but overall the quality of life of infants and children and teenagers have improved a lot. A lot of them used to die in their teenage years due to lung damage, liver failure. They were on the transplant list, a lot of complications with diabetes. But now with quicker diagnosis, which most, as I said, that we have universal newborn screening for cystic fibrosis. So now these babies get diagnosed at birth, and the prevention of all these complications are possible. So what they do is that there are multiple aspects of it. One is to keep your lungs healthy, and in order to do that, they do this chest physical therapy, which they can be done by mother, kind of patting on the chest. They're taught how to do that. And there's also a little vest. It's just like a coatee, which you can put on the kid. It's plastic, and then you can turn it on and it vibrates, and it helps to bring up the sputum and mobilize it, so keep the lungs clear. Then you kind of encourage them. It causes coughing and the sputum comes out. So this is something which moms have to do daily. So it has made a huge difference. The pharmacologic treatment, they get bronchodilators like albuterol to relax their lungs, so they can clear their lungs better. The recombinant human deoxyribonuclease is given by nebulizer, and it breaks down the DNA complexes in those thick mucus plugs, and it also keeps the lungs clear. They're also given in a different, some antibiotic prophylaxis, where antibiotics are given on a regular basis, which also helps to prevent the infection and decrease damage to the lungs. Tobramycin is used, azithromycin is used, and the most recent therapies are CFTR modulators. I have to drink water, so I'm just going to pause for a second. So CFTR modulators, there are many CFTR modulators. It's a completely new class of medicine. IVA capture is one of them, but there are other medicines as well, which actually works on the defective CFTR. So it makes a huge difference. And this is a treatment which is kind of has a very complicated protocols, but outcomes are expected to be very good. Then you work on prevention of infection. You have to make sure that patient gets all immunizations, they get their pneumonia vaccine, they get their flu vaccine, everything which can cause lung infections, you want to prevent it. So if they get any acute exacerbation, then they are admitted to the hospital and they are treated quickly. And usually the symptoms of acute exacerbation are that they are very tired, they're not able to eat, they're losing weight, they can be they might have fever, they have much more cough than usual, and the sputum production actually goes up too. So when we admit them, we usually treat them with IV antibiotics. We give them very extensive chest physical therapy with respiratory therapists, and that kind of helps to treat the pulmonary exacerbation. And then you look at the results of the sputum from their previous hospitalization, because they have all kind of different bacteria, and it keeps changing. So you have to find what they had last time, and then they are started on antibiotics for it. Now for pancreatic insufficiency, they are started on vitamin replacement, because of course that's something which they are not able to get the way all of us get. And then they're also started on pancreatic enzymes so they can get the nutrition. So actually one of the reasons why cystic fibrosis is very common on the exam questions is because a lot of your vitamin deficiencies are covered with it too, as it is a multi-system disease. So I kind of gave you symptoms of all these deficiencies. Like vitamin A deficiency will cause night blindness and conjunctival and corneal xerosis. Vitamin D deficiency, which is actually very important in children because they are growing, so their bones will get weak, they have broken bones. Vitamin E deficiency is going to give them peripheral neuropathy. Vitamin K deficiency is coagulopathy, easy bruising, and it causes significant problem for them. Pancreatic insufficiency is in 85% of CF patients, and it causes malabsorption of fat and protein. That's why they have bulky, bad-smelling stools, which parents will kind of register it actually as diarrhea. So remember the 15-month-old I was talking about when I started this talk, the mom was reporting diarrhea. So it is this bulky stool and poor weight gain, and of course, failure to thrive. The baby which we talked about was not gaining weight and was really small in size as well. So these patients need it lifelong, and they have to take these enzymes with each meal. So before they eat, they have to take it. And then you kind of adjust their doses. And you have to make sure that you don't give them too much because it can cause fibrosing colonopathy. So this is how I try to present this disease, which you will not see in Pakistan, and it's very hard to learn it when you don't see any patients with it. My email is nshafi, is NSHAFI 50@gmail.com. If you have any comments and questions, I would look forward to those. And it was a pleasure teaching you cystic fibrosis.